So we are continuing. We were talking about the ketogenic diet and the participation in this chronic cholelithiasis, right? Cholecystitis. So please get a good gastroenterologist, nutritionist, and PCP that are willing and able to do your blood test every 3 months so you can see how your blood is telling us the story of how well you are doing. Okay, this is very important because you don't want to lose an organ. Any organ that is removed from your system, I don't care if it's a small organ, a big organ, can cause metabolic imbalances. So make sure you follow the diet and recommendations of a good nutritionist. Pancreatitis and cholangitis, which is the bile duct inflammation, can occur as chronic complication of cholecystitis. These problems result from backup of bile throughout the biliary tract. Bile obstruction leads to jaundice. So we are also going to have jaundice, icterus, which is the yellow coloration of the eye sclera, and also just remember that pruritus also is going to happen, okay, or a burning sensation, because this is the result of the accumulation of bile salts. Because urobilinogen accounts from the normal brown color of feces, gray color stool results. Remember, the urobilinogen is going to take a role when the bilirubin enters the colon, right? Water-soluble bilirubin is normally excreted by the kidneys in the urine. When an excess of circulating bilirubin occurs, the urine becomes dark because of the kidneys' effort to clear the bilirubin. So etiology, its familiar or genetic tendency appears to contribute to the development of cholelithiasis, but this may be partially related to familial nutrition habits, excessive dietary cholesterol, and sedentary lifestyles. And here I want to make a parenthesis. From 0 to 7 years old, from 0 to 7 year old, we create memory in ourselves, not only in the metabolic processes, not only we teach our children how to eat and we create good habits, but we create memories in the nervous and the brain cells. How come? When that kid is taught, learn to eat French fries, high fats, fried steaks, chocolates, okay, that children is in high risk to become obese, not overweight, obese later in life. Okay, from 0 to 7 is the way you should educate your children to eat your vegetables, your healthy foods. Now, in terms of brain and nervous system, okay, those memory cells are going to be impacted if this children is in trauma, fights, violence at home. Now, from 0 to 7, oh, and is going to affect their learning. So when I see patients that are aggressive, disrespectful, that they cannot control themselves, that they don't have tolerance, they are really rude, I question myself what happened in their childhood, what type of parents they have, what have they seen, because there is a history behind, okay? And then you start analyzing each behavior, because believe me, within violence and aggression, there are specific characteristics, okay? So that is going to tell you what happened in the past. That is mathematics. The same thing happens when you see an obese patient, okay? So you can tell you're going to find in the family the same habits, what this patient was eating during childhood. Okay, what were the habits of the mother? Maybe they were having socioeconomical problem, financial issues, and she didn't have the money to get the proper food. So all those factors you need to consider. Okay, that's why it's very important when you see this type of patients to refer them to nutritionists, gastroenterologists, because if the patient is going to start prescribing themselves or is going to start deciding, tomorrow I'm going to start a ketogenic, tomorrow I'm going to start this Atkins diet, this is going to cause problem because you don't know how the memory cells are, number one, and number two, what are the nutritional habits. So let's continue. Patient care. The highest frequency of gallstone production occurs among the American Indian and Mexican American populations. Yes, of course, they eat a lot of carbohydrates, they eat a lot of fried foods, okay? Obesity is a major risk factor for gallstone production formation, especially in women. And pregnancy and drugs such as hormone replacements and birth control pills alter hormone levels and delay muscular contraction of the gallbladder, decreasing the rate of bile emptying. The incidence is higher in women who had multiple pregnancies. That's good to know. Therefore, some clinicians continue to refer to the patients most at risk for acute cholecystitis and gallstones by the 4 Fs. Remember this. So female, 40, fat, and fertile. Remember this. That's good to know. NCLEX alert. Okay? Yes. This is very important. When you go to the ER, when the patient presents to the ER and with the upper right quadrant pain, the first question, the resident, the doctor is going to come, is going to ask you, how old are you? What is your nutritional habits? Are you taking any contraceptives? This and that. He's going to go through the 4 F, female, 40, fat, and fertile. Okay. So risk factors for cholecystitis, and the same thing, if a patient presents to ER with a lower left quadrant and the resident is suspecting irritable bowel syndrome, okay, they are gonna go very deep in questioning your emotional status. How is the relationship with your parents? He's gonna try, because IBS is related to the emotional, right? You can have diarrhea or constipation. They are gonna ask you, how are you doing with your partner? How are you doing if there is any violence at home? How is your stress level? What causes the stress? The psychological part is going to be assessed. Here is the upper right quadrant. Okay, so the assessment is going to be based on female, 45, and fertile. Okay, cholecystitis, women of all ages, risk of calculi increases with aging. American Indian, we know that. Obesity, we know that. Rapid weight loss, we just spoke about it. The fasting, the low fat diet, increasing serum cholesterol and lipids. That's why I strongly recommend you to do blood tests every 3 months. Woman on hormone replacement therapy, please understand, I am recommending this if you decide to make these diets, the ketogenic diet, the Atkins diet, okay, or if you had previous history of gallstone formations. So here you go, the whole list between the genetic factors, the family history of gallstones, Crohn's disease, sickle cell disease, diabetic type 2. So what are we gonna do? First, we're gonna recognize the cues, the history. We're gonna ask about the excessive fat and cholesterol intake, the diet high in fat, high in calories, low fiber, all these little details about the nutrition, okay? Also, you're going to analyze, especially if this is a young woman, what type of diet they are getting, okay? So when they are eating fatty foods, what type of symptoms they are having? Are they having flatulence, dyspepsia, which is an epigastric pain sensation often related to heartburn? Are we going to ask, we need to ask about eructation, indigestion, vomiting, if there is any sedentary lifestyle habit, if anybody in the family had a gallbladder disease, oral contraceptive use, all this. Now, the physical assessment, patients with cholecystitis have abdominal pain. Ask the patient to describe the pain, the intensity, and for that you're going to use your all cards mnemonic. Remember your onset, location, duration, all card mnemonic, characteristic, alleviating and aggravating factors. And we spoke about the all cards mnemonic before, so you're going to apply this in order to assess for pain. And also you're going to do the Murphy sign. And let's watch this video to see how the Murphy sign is usually done. Okay, so you have an idea of how is this done.
Murphy's sign is a sign of acute cholecystitis, which is an inflamed gallbladder. You should palpate the right upper quadrant and ask the patient to take a deep breath in. As the diaphragm relaxes, the patient's inflamed gallbladder catches on your fingers, causing the patient to feel pain. Okay, could you take a deep breath in for me?
And he stopped breathing, right? That's the Murphy sign. Usually this is done by providers and nurse practitioners or PA. It can be done even at the bedside or maybe when the patient is standing up, and I'm going to explain to you how you can do that when the patient is standing up if you are in outpatient clinic. So also we are going to have another, do you remember I told you assess for pain that happens in other organs? So here you have below the ribs, okay, is this is the Murphy sign, but also you're going to have the pain is going to radiate to the shoulder or scapula, okay, also known as the shoulder blade. So older adults and patients with diabetes mellitus, that's type 2, may have atypical symptoms of cholecystitis, including the absence of pain and fever. Hello, hello, that's good to know, okay. So basically, I have not seen this question, but if you come across any family member that is not having pain, even fever, but is having discomfort, flatulence, the cholesterol blood work is increased, is elevated, you can actually assess for cholecystitis with the Murphy signs. Uh, Localized tenderness may be only presenting sign, the localized tenderness. Okay. The other patient may become acutely confused, delirium as the first symptom of gallbladder disease. So pay attention to that because our elderly population, they have a totally different presentation, especially also diabetic patients. Okay, critical rescue, the severe pain of biliary colic is produced by obstruction. We know this. When a stone is moving through or is lodged within the duct, tissue span occurs in the effort to get the stone through. Okay, so biliary colic may be very severe, and that it occurs with tachycardia, pallor, diaphoresis, and prostration, extreme exhaustion. So this is something that you need to see. Somebody that is having diaphoresis, tachycardia, pallor, and the pain is specific in the right upper quadrant, you can suspect about possible shock caused by biliary colic, and this you need to take this patient immediately to ER or call the rapid response team if the patient is already in the hospital. Okay, and don't leave the patient never by itself, and keep the head of the bed flat if shock occurs. If you put the patient in a sitting position, you're going to cause more pressure in that area. That's why here you are going to keep the head of the bed flat in order to relieve the pressure, okay? Advanced physical assessment for rebound tenderness. The Blumberg sign is another type of assessment. And we're going to watch the video, so you're going to see the difference between the Murphy and the Bloomberg sign really quick. Thanks God these videos are like 30-40 seconds, I think. This is 25.
The next we're going to look at is rebound tenderness. Rebound tenderness is pain with release of the pressure. So what I'm going to do is I'm going to press down on your abdomen, and you let me know if it hurts more when I'm pushing in or when I'm pushing out, or when I'm letting go, excuse me. So I push in and let go quickly. Where was there more pain? In. Okay. So that would be tenderness, but negative for rebound tenderness.
Perfect. So that's another way to assess. And then so pain that results from the rebound of the palpated tissue may indicate peritoneal inflammation. Now, in chronic cholecystitis, patients may have slowly developing symptoms and may not seek medical treatment until late symptoms such as jaundice, clay-colored stools, and dark urine occur from biliary obstruction. Icterus may also be present. Steatorrhea, fatty stools occur because of the fat absorption. And the key features of cholecystitis are going to be episodic or back upper abdominal pain or discomfort. You have anorexia, pain triggered by a high fat or high volume meal. So that's why you need to be very specific in your assessment. What did you eat today? What time? Is this happening often? Is it a big meal, right? And then you have the regulars, nausea, dyspepsia, eructation, flatulence, rebound tenderness. We analyze this already. Fever, jaundice, steatorrhea. Okay, I want you to remember this. That's good to know. Jaundice, clay-colored stools, dark urine, steatorrhea are symptoms of chronic cholecystitis. That's good to know. Now, older adults become dehydrated much more quickly than other age groups, and they may not present with a fever, and we spoke about that. Monitor for a new onset of disorientation or acute confusion due to decreased blood volume available to oxygenate the cells of the brain, hypoxia. Laboratory assessment, you are going to find sometimes that on the assessment, they are going to try to rule out peptic ulcers, hepatitis, and pancreatitis. Just think about the location. Right upper quadrant, we have the most part of the liver, we have the ending of the stomach, we have the curvature of the duodenum, and we have the head of the pancreas. So they are going to try to rule out all these organs besides the gallbladder, right? So we're going to see the white blood cell count elevated, and that indicates inflammation. Also, your alkaline phosphatase, aspartate, aminotransferase, and lactate dehydrogenase are going to be elevated. Okay, so other diagnostic assessment, they are going to probably do x-rays, abdominal x-rays, and they are going to find calcified gallstones. And ultrasonography or of the right upper quadrant is the best initial diagnostic test for cholecystitis. It is safe, accurate, and painless. So acute cholecystitis is seen as edema of the gallbladder wall and pericholecystic fluid. Now, there is another hepatobiliary scan. That's another test that can be performed to visualize the gallbladder and determine patency of the biliary system. In this nuclear medicine test, a radioactive tracer or chemical is injected. Then you have another one, which is called the endoscopic retrograde cholangiopancreatography, ERCP. We are going to refresh our memory on this test because I presented this on the assessment of the gastrointestinal system in that chapter, but let me refresh your knowledge.
Endoscopic retrograde cholangiopancreatography, ERCP, is a procedure that combines endoscopy and fluoroscopy to diagnose and treat disorders associated with the pancreatic and biliary ductal systems, as well as the liver, gallbladder, and pancreas. Endoscopy is a medical procedure in which an endoscope, a thin, long, flexible tube with a light and tiny camera at one end, is inserted into the body to examine an internal organ or tissue in detail. Fluoroscopy is a medical imaging technology that uses radiography or a continuous X-ray beam passing through your body to produce real-time moving images of a body part being examined on a monitor. Surgical procedure. You will be asked to lie on an examination table for the procedure. The procedure may be performed under sedation and local anesthesia or general anesthesia. An intravenous (IV) needle will be placed in your arm. After administering a local anesthetic to the throat, your doctor will insert an endoscope through your mouth, esophagus, and stomach to reach the first part of the intestine called the duodenum, where the bile and pancreatic ductal systems open. A small camera mounted on the endoscope captures images which are magnified and viewed on a monitor. Your doctor will locate the opening where the bile and pancreatic ducts empty into the duodenum. A catheter will be inserted through the endoscope into the ducts, and a special dye called a contrast medium will be injected into the ducts through the catheter to make them more visible on X-rays. Fluoroscopy, live X-ray imaging, is performed to identify any areas of blockage or other abnormalities. Your doctor may then pass tiny tools through the endoscope to open blocked or narrowed ducts, remove or break up gallstones or excise lesions. Temporary stents may be inserted to keep the ducts open or to avoid bile leaks that can occur after gallbladder surgery. The procedure often takes between 1 and 2 hours.
Thank you so much. Excellent video. Very short, straight to the point, and you can see how the ERCP is done. Also, there is another one. It's called magnetic resonance cholangiopancreatography, okay, which can be performed by an interventional radiologist. And before the test, they are going to ask you if you have history of urticaria or other allergies, because there's a contrast material that is going to be administered. So what are we gonna do? We have to manage acute pain, right? So the intervention is supportive care by relieving symptoms and decreasing inflammation. NCLEX question: a young adult client admitted with a diagnosis of cholecystitis from cholelithiasis. So it's the gallbladder inflammation from cholelithiasis from gallbladder stones, has severe abdominal pain, nausea, and vomiting. Based on these assessment findings, which patient problem is the high priority for nursing intervention at this time? Do we need to control the anxiety, the risk for dehydration? Are we going to manage the acute pain or the malnutrition? So the answer is acute pain. Non-surgical management, most patients, we're talking about non-surgical, right? So most patients find that they need to avoid fat foods to prevent further episodes of biliary colic. With whole food and fluids if nausea and vomiting occur. IV therapy is used to prevent dehydration. Acute biliary pain requires opioid analgesia, morphine, hydromorphine, or dilaudid. All opioids can cause some degree of sphincter of Oddi spasm, and on top, they may cause constipation. Okay. So the one that is used the most is ketorolac. A potent NSAID may be used for mild to moderate pain. Now remember, there is a risk for GI bleeding. So with this NSAID, it's very potent. Provider prescribe antiemetics, and you as a nurse need to ask any history of bleeding, of gastritis, of ulcers, okay, before going through and administer this medication. Remember, you are the last step between the doctor's prescription and the patient, so you can stop any medication with the correct information, right? Then antibiotic therapy also can be given. Oral bile acid dissolution or gallstones agents such as ursodiol and conediol may be given as a long-term therapy to dissolve or stabilize gallstones. A gallbladder ultrasound is required every 6 months for the first year of therapy to determine the effectiveness of the drug, and also kind of letting the patient reflect on the nutrition they went through in these 6 months in parallel to the medication, right? Each patient on this type of drug therapy to report nausea, vomiting, or severe abdominal pain, especially if it radiates to the shoulder. We know that, right? To the scapula. To take the medication also with food and milk. So there is another therapy that is non-surgical, that is done to patients that are not good surgical candidates, and this treatment is similar to the one they use to dissolve kidney stone. It's called extracorporeal shockwave lithotropy. So I'm going to show you how they are doing this for the kidneys, and you will have a better idea of how they can do this for gallstones. This is a video from the Cleveland Clinic.
Shockwave lithotripsy is a surgical procedure in which high-energy shock waves are transmitted through water and directed at the kidney to break the stone into smaller pieces. This makes it easier to pass them through the urinary tract. Shockwave lithotripsy is an outpatient surgery, and you'll go home the same day. For this procedure, you'll have general anesthesia, which means you will be asleep during the surgery. If you are on blood thinners, you must be able to stop taking them before this procedure. After the procedure, you may have discomfort, flank pain, bruising, nausea and vomiting, and blood in your urine. You may also pass stone fragments for several weeks. The benefits of shockwave lithotripsy are that there is no incision and the risk is low. The success rate of this therapy depends on several factors, including the size and hardness of the stone and the patient's body type. Your doctor can provide you with your likelihood of success with this treatment. These are the risks of shockwave lithotripsy. You may need a second procedure, such as a ureteroscopy, in order to clear all the stones. There is a 1 in 1,000 or 0.1% risk of serious bleeding. If this happens, you would need a blood transfusion. There is a 1 in 100 or 1% risk that you will need a second procedure, such as a stent or ureteroscopy. There is a 1 in 100 or 1% risk that after the procedure you will have severe pain that would require immediate medical attention. And there is a small risk that you will get sepsis, which is a serious infection. You can usually return to your normal activities 2 days after a shockwave lithotripsy procedure.
Excellent. So you have an idea of how this test is done. So a therapeutic bile acid such as ursodeoxycholic acid may be used after the procedure to help dissolve the remaining stone fragments. Okay, so there is also percutaneous transhepatic biliary catheter drain using CT or ultrasound guidance to open the blocked duct so bile can flow. Cholecystectomy. So now we are going to the surgical. Cholecystectomy is the surgical removal of the gallbladder. One of two procedures is performed: the laparoscopic cystectomy, or in rare cases the traditional open approach cholecystectomy. The most common is the laparoscopic. So it's the gold standard. Complications are not common. Bile duct injuries are rare. Postoperative pain is less severe. Recovery is quicker. So we have to reinforce what to expect after surgery and review pain management, deep breathing exercise, incisional care, and leg exercise to prevent deep vein thrombosis. That's very important. It's like a regular surgery, right? All the care like a regular surgery. There's no special preoperative preparation. During the surgery can make a small, very small midline punctures at the umbilicus. Okay, this is information for the surgeons. Removing the gallbladder with the laparoscopic technique reduces the risk for wound complications, but still, you're going to monitor, right? Even though the patient probably may go home the same afternoon or maybe the following day, you're still going to assess for infection. After a laparoscopic cholecystectomy, assess the patient oxygen saturation level using pulse oximetry frequently until the effects of the anesthesia have passed. Remind the patient to perform deep breathing exercises every hour. That's good to know. NCLEX alert. Offer the patient food and water when he or she is fully awake and monitor for the nausea and or vomiting that often result from anesthesia. If needed, administer antiemetic such as ondansetron, hydrochloride, either IV, push, or as disintegrating tablet. Be sure to have the head of the bed elevated, and the same day surgery you need to prevent aspiration from vomiting. And this is good to know. I would say this is one of the most important topics you need to remember. Post-care. The patient is usually discharged from the hospital or surgery after the same day, although older or obese patients may stay overnight. We know that. Some patients are able to return to their usual diet after surgery, whereas others must carefully avoid high-fat foods. A large intake of fatty foods may result in abdominal pain and diarrhea, which could result in a mild post-cholecystectomy syndrome. Okay, so the mild cholecystectomy syndrome, we have a table here, but first let's review that a patient who has a traditional open cholecystectomy is similar to the care for any patient who has an abdominal surgery. We know that. Encourage the patient to use coughing and deep breathing exercises when pain is controlled and the incision is splinted. That's good to know. Coughing, deep breathe every 2 hours. That's good to know. The patient is NPO until fully awake after surgery. Document his or her level of consciousness, vital signs. We know that. That's a post-surgery care. Advance the diet from clear liquids to solid foods, of course. Promoting nutrition. The patient will not lose weight or will regain usual weight if indicated to meet metabolic needs. So the cholelithiasis nutrition, clients with cholelithiasis should avoid foods high in fat and cholesterol, such as whole milk. Listen to this: whole milk, butter, fried foods, lasagna, low-fat milk, grilled cheese, creams, and cream of potato soup all have high levels of fat. The reason I'm mentioning this is because patients after the surgery, they want to go back to their regular diet, which causes the problem, right? Interventions to promote nutrition. The patient with cholecystitis may decline foods because of abdominal discomfort. The patient diet should be high in fiber and low in fat. So you have to educate the patient to weigh regularly to assess for stabilization of weight or report concerns associated with weight loss. Okay, and also to monitor BUN, your blood urea nitrogen, your prealbumin, albumin, and total protein and transferrin levels to assess ongoing nutrition status. And this, your prealbumin and albumin, is going to tell you if they need protein and how much of that they need to get per day. Common causes of post-cholecystectomy syndrome. Do you remember? We spoke about it. So if it's biliary, it's going to be because of diverticular cord pressure, pancreatic or liver mass, a sphincter of Oddi dysfunction, a new CBD gallstone, If it's non-biliary, it could be coronary artery disease, intercostal neuritis, psychiatric or neurologic disorders, believe it or not. Care in the transition management, assess the patient and family knowledge of the disease and provide teaching as needed, especially try to get in contact with the person who's preparing the meals at home, okay? And to educate them to avoid excessive intake of fatty food, especially your fast food visits, your visits to the fast food restaurant. And also recommend a weight reduction program. If there is a repeated abdominal or epigastric pain with vomiting and nausea, this may indicate that probably we have a possible post-cholecystectomy syndrome. Now, management depends on the exact cause, but usually involve the use of endoscopic retrograde cholangiopancreatography to find the cause of the problem and repair it. So at the end, what we are looking for is to control the abdominal pain and to have adequate nutrition available to meet metabolic needs. Okay, so here we have finished the cholecystitis. When we come back, we are going to review acute pancreatitis. Thank you.